it will happen, because you remember even in Cadbury, so clear, there was no such policy.
Hello.
But
Okay,
you
I
always
think
knew
we
that
are
there is a
live on
threshold called
YouTube now.
Hello.
अगर आप
You can
40%
start.
नहीं बना
Okay,
रहे
sir,
हैं,
okay.
आपको ये निकालना, ये
मैं
थोड़ा
रूम पे
target
हूँ, जब मेरी क्लास थी
कुछ
ना।
भी करके आपको
Hello.
40 दिखाना है।
I think if
अगर वो
everyone
दिखा
else
सकते हो तो
can
ठीक है,
mute.
नहीं
Yeah.
दिखा सकते तो छोड़ दो, right?
So,
अच्छा, नहीं,
may I
मेरा
request
class-
everybody to mute their,
percentage नहीं, हमको
except those who are
1.5
volunteering or those who want to talk.
SFGP बोलते हैं यहाँ पे, system जो भी है।
Um,
नहीं हो रहा है तो आप
Give me 1 second, Surendra. I will make
Yeah,
you as host.
Okay.
I'm trying to find out where I can make you. Give me 1 second. I'm just clicking that.
Yeah. Can go to my icon, sir, that Medicines India.
Yeah, I've done it.
Yeah.
Okay,
Yeah.
you're a host now.
Okay.
Is that right?
Yeah, yeah. Yeah. I'm
Okay.
now host now. Okay.
Yeah, carry on.
Hi, good evening, everybody. I think this is a great initiative by GAME to give a first-hand experience by making you attend a mock Viva so that it becomes a conditional reflex for you when you go for your exam. And it becomes very easy to answer questions and prepare yourself to brace the storm, isn't it? So having said that, I think this is the third or fourth mock Viva. So without wasting much time, we will just go into the session. Let me share the screen 1 minute. And we have here with us Dr. Shiv. He's our Gyan Guru, to mean literally. Sir, Shiv sir, you just want to talk a few words before I just share my screen? Sir, hello.
Hi. Yeah.
Hi, sir. Yeah.
Hello, everyone. Thank you, Suren, for taking up this session.
Yes.
And I just luckily got free today early, so able to join it because most of the times I'm still working at this time. And thank you to also the people who have, offered to be doing the mock Viva with you. Is Minoti doing it, or sorry, I forgot the people who are doing it?
Dr. Sangeeta and Dr. Deepak, two volunteers have already.
Yeah. Thank you for volunteering, guys. And I think we got quite a few other people as well who are actually also listening to that. And I'm sure this is going to be very useful. Over to you, Suren.
Yeah, thank you, sir. So today's session, actually, we had 2 topics on the basic sciences and 1 clinical topic. As we all know, the basic structure of the EDAIC Viva, it is 4 tables, which 25 minutes on each session, and 2 examiners, which 12.5 minutes each. So first table, you'll have the basic physiology, the second table, pharmacology, third clinical, and fourth critical care, emergency, and acute advanced life support questions. So today we have the topic on, 3 topics, that is the respiratory dead space, ventilation perfusion, VQ mismatch, second topic, and third topic is a chronic obstructive pulmonary disease, a patient who has this disease coming for either an elective or an emergency surgery. So this will be the topics for discussion. So we have with us 2 volunteers, Dr. Sangeeta and Dr. Deepak, who have volunteered to participate in this mock Viva. And in the meantime, if we have any other impromptu volunteers, you can just join this mock Viva. It will be helpful to you. Okay.
Surendra, Guru here. And thank you very much. I'm going to log out. Okay. If you got any problems, don't hesitate to text me. Okay.
Sure, do. Okay. Bye. Dr. Deepak, are you with us?
Yeah, I'm here, sir.
Yeah. So good evening. How are you?
Yeah, good. Good evening, sir. I'm good, sir.
Yeah. So can you just talk about yourself? Where are you?
Sir, I am situated right now in KD Medical College, Mathura. I am working here as an assistant professor in Department of Anesthesia.
Great. So when is your exam?
I have, sir, registered for exams in October, 27th, 28th, 29th October.
So that will be an online, is it?
Yeah, online exam.
Okay. So I think this will give a fair idea of how to proceed. So you know that the first 10 minutes you will have a question, a main stem question, which will be given 10 minutes before, and you will have 10 minutes to just organize your thoughts, isn't it?
Yeah.
So my suggestion and my experience with that is, because I had face-to-face experience in Barcelona, so I don't have much knowledge about online exam, but face-to-face, we had 10 minutes. They gave a paper with a question. And what I did was I wrote what all things I know about that particular topic in those 10 minutes, including I drew graphs. If there is any table, I made a table and I labeled X and Y axis with units, and I marked everything, all diagrams legibly, whatever I could do in the 10 minutes. Whether if it is a descriptive question, I just made a thought process, like what will be my first heading, what will be my second, like that. So, and I made a subheading, and I made a framework of how I should present that particular answer. Why it helped me was, and whenever the question, whenever you face the examiners, they will just ask you to start. Okay, so you don't know what to do. So if that question has got some definition, start with the definition, and you just keep going on. Means first 2 minutes is the first important time to make your impression, the best impression, because you have just 25 minutes to prove that you are worth, isn't it? So first 2 minutes, don't hesitate to start, and do not stop till the examiner asks you to stop. Okay.
Okay.
So that main question can give you a big, impression on the examiner's mind, and they will assess you on that basis. Okay. So that was my experience. If anybody has any other experience, they can share. Okay. So.
Suren.
Yes, sir.
This is what we used to actually say. These are open-ended questions in for the FRCA. You define, classify, or die.
Okay. Okay.
So know a definition, be able to classify. Okay. And you actually won half the battle.
True. True, sir. True. Because you cross half the well uninterrupted. Hello.
Yeah, hello.
Can you hear?
Yes, sir, I can hear.
Yeah. So just we'll start with the dead space topic. So if this was your lead question, with what is dead space, what are the types of dead space, and how will you measure individual components, explain with suitable graphs.
Okay.
So this could be your lead question, isn't it? Main question which you can face. So if you're having online, you can take a paper and you'll be given 10 minutes. You can keep writing whatever you know about this, and draw 1 or 2 graphs which is pertinent to this question. Like if you have any specific graphs to measure the individual dead spaces, and keep it ready. And you'll have another 5 minutes time to just face the examiners. Okay. Okay.
Okay.
You want a minute to just organize your thoughts?
Yeah, just give me a minute, sir. I'll just organize my thoughts first of all. Okay, sir. So shall I start?
You can start now. Yeah. Yeah, you can start now. Yeah.
Yeah. Okay. So the dead space is the volume of air that does not participate in the gaseous exchange. There are three types of dead spaces basically: the anatomical dead space, the alveolar dead space, and the physiological dead space. The physiological dead space comprises both anatomical and the alveolar dead space. Now, the anatomical dead space is that part of volume of air which is in the basically in the conducting zone of the airways, and that does not participate in the gas exchange. That constitutes mainly 150 ml or 1/3 of the tidal volume. So, to measure the anatomical dead space, Fowler's technique is used. In this technique, we ask the subject to inhale 100% oxygen with a full maximum inspiration and then expire normally through a analyzer which detects the nitrogen. So initially, the dead space is exhaled, which contains no nitrogen because it's been replaced with 100% oxygen. So initially, there is no nitrogen, but as the gases start coming from the alveoli, the nitrogen content starts increasing, and then in the phase 3, there are only alveolar gas present, which contains the maximum nitrogen, and that causes a plateau. So this is the graph which is plotted against the percentage of nitrogen with the time graph. Now, when we plot this expired nitrogen percentage with the volume of air, we get a sigmoid shaped graph, and on that sigmoid shaped graph, just a minute, I'll just draw that. So if we draw the graph of expired nitrogen with the volume of air, and we divide this in equal half, the first phase into equal half.
You
So
divide
this
the
is
first
the volume.
phase or the second phase into equal half?
We divide this into equal half, and this is the volume which constitutes the anatomical dead space.
Okay.
So this is the anatomical dead space. Now the second dead space is the alveolar dead space. Alveolar dead space is that volume of air which does not participate in gas exchange in that way that it contains in those alveoli from which there is no blood flow from those alveoli. So now it does not occur physiologically usually, but in certain pathological conditions, alveolar dead space increases. Like if there is respiratory, like pneumonia, if pulmonary edema is there, it causes the alveolar dead space. The alveolar dead space is measured through the Bohr's equation. Bohr's equation is based on the fact that the expired carbon dioxide comes only from the alveoli only. Now, sir, should I derive the full equation of the Bohr or like?
Yeah, actually, these examinations, like European diploma examination, has got more tendency to ask you to derive the Bohr's equation, and
Okay.
examiners are very fond of seeing you how you derive the equation, and you talk while deriving the equation. So it will be better if you have a question on dead space. You have to draw before you meet the examiner. You must draw the Fowler's graph, and you should derive the Bohr's equation side by side and keep it ready.
Okay.
So this saves a lot of time when you face the examiner, and then you can answer more questions. So more questions you answer, there's a high probability that you get good marks.
Okay, sir.
So that is my suggestion.
Thanks.
And,
So should this? Yeah, please.
Go ahead. Go ahead.
Okay, so the Bohr's equation is based on the fact that the expired carbon dioxide comes only from the alveoli. So it goes that dead space volume is multiplied by the alveolar concentration, dead space into the tidal volume is equals to the alveolar
tidal volume
multiplied.
The tidal volume
The
is
tidal
equal
volume
to
multiplied by dead space.
No. The tidal volume is equal to the dead space volume plus the alveolar volume. Okay.
Yeah. Yeah.
Yeah, VT is equal to VD plus VD plus VA. That is the equation. Yeah. Now you continue. Yeah.
Okay. Sure. So now the okay. So that the dead space volume into the carbon dioxide concentration, the expired carbon dioxide concentration, we write like FCO2 is equals to the alveolar ventilation multiplied by the alveolar concentration of the carbon dioxide. FE by FA. So VD into FE is equals to VA into FA. Now, if we shift this equation, VA is equals to VT minus VD.
Okay.
Into FA. Now, if we open this equation, it's FA into VT minus FA into VD.
Now VD, for your you can keep deriving this equation. So if you are facing this in your exam, see, you are losing a lot of time. Okay.
Yes, sir.
So if you can make this both equation before you face your examiner, that will be very useful. Okay. You can just show the paper to the examiner and you can just talk through it and you'll save a lot of time. Okay, now it is just a mock viva. So these are some valuable things which you can organize yourself before you face your final exam. Okay?
Yeah, sure, sir.
Okay, now you come to the final equation. What is the both equation? The final equation. We'll see
final
the
equation is VD upon VT is equals to fractional alveolar carbon dioxide minus fractional expired carbon dioxide upon fractional alveolar carbon dioxide. Now, this fractional alveolar concentration is dependent on the partial pressure. So we replace the equation with the partial pressure. So VD upon VT is equals to P alveolar CO2 minus P expired CO2 upon P alveolar CO2.
Very good. So this is your final equation. So what is the normal dead space volume which you expect?
Normal dead space volume is 1/3 of the tidal volume.
Okay. Do you have any percentage for that?
It's 30% of the tidal volume.
Yeah. So it is around 20 to 35% of your tidal volume is normal dead space. Anything above 70% will make oxygenation and ventilation an abnormal situation. Okay. So good. You answered well, and we almost had almost 7 minutes we had in the discussion. So you described about what is anatomical dead space. So it is nothing but the air, the amount of air present in the conducting airway up to the terminal bronchiole, which doesn't participate in your respiration, isn't it?
Yes.
Which you told. Then you told about the factors affect the amount. What is the normal amount? That is either 2 ml per kg or
150 ml.
150 to 200 ml or 2 ml per kg or 1/3 of your total tidal volume. So anything is okay. Any three things you can tell. Then if you can add, what are the factors affecting anatomical dead space? Do you know any factors which increase or decrease anatomical dead space?
Yeah. So the factors which affect the anatomical dead space, factors which increase the dead space, anatomical dead space are with increasing height of the patient. If we use artificial airway, it increases the anatomical dead space. And if we take a deep breath, then it increases the anatomical dead space. The factors which reduces the dead space are if the patient is if the patient has got lying down, supine patient.
So suppose if you use a tracheostomy, do you decrease the dead space or increase the dead space?
It decreases the dead space.
Yes.
Tracheostomy tubes.
Okay, if you cut the tube, it reduces the dead space. Okay.
Yes, sir.
Okay. Then Then you told about the anatomical dead space. Good. Now, what is alveolar dead space, which you explained? This amount of air which doesn't participate in the ventilation, but it is present in the alveoli, isn't it?
Yes.
And so what are the factors affecting both? So which we saw, isn't it? So is there any other factors which you want to attribute to alveolar dead space?
If there is decreased cardiac output, it causes increase in the alveolar dead space. And if there is any pulmonary
positive pressure ventilation, whenever you initiate any positive pressure ventilation, the alveolar pressure increases. So
yes,
that will also increase the alveolar dead space.
Dead space.
Okay.
Basically, it increases the zone 1, and that will cause to increase the dead space, alveolar dead space.
Okay. So alveolar dead space, do you find it in a normal physiological condition?
No, alveolar dead space is not found normally in physiologically conditions.
So either whenever there is a hypotension due to bleeding or some other cause.
Yeah, then there will be.
Yeah. Whenever you initiate positive pressure ventilation, there is an increase in the alveolar dead space. Okay.
Yes.
Okay. So do you know any other dead space other than these two?
Sir, apparatus dead space, which we talk about in anesthesia practice. So it is the volume of air from the patient mouth, from the patient conducting zone till the part of the apparatus from where there is the oxygen in the inhaled and the exhaled port got separated. So till that part, it is counted as apparatus dead space.
Okay. So can you explain with me an example in your day-to-day practice?
Like if we are using a vein circuit, or if we are using a normal ventilator circuit, so the apparatus dead space constitutes from the Y-piece connector till the conducting zone, or till the endotracheal tube of the patient.
Okay. So this we already saw. How can you measure an anatomical dead space? So you explained us already in detail about Paulus method and Bohr's equation. And we saw this physiological dead space also, right?
Yes, sir.
Okay, good. So you answered well. I think few what is the modification with using the graph before, because you didn't have time here, of course. So in your exam, you can take time to draw this graph beforehand. Yes, and keep it and try to mark the X and Y axis in correct units. They don't bother about numbering the scale of the graph and all, but they want to see correct units on X and Y axis, and write the salient points, like as you mentioned correctly, that the midpoint of the phase 2 from this 0 to this place is known as anatomical dead space, which constitutes around 150 ml. And you also have to mark the closing capacity in this. Okay, this phase 4 is the closing capacity. So when, as you explained, that after a tidal expiration, patient inspires 100% oxygen to his vital capacity, and then slowly expires to his residual volume. So first you explain the method, then you talk through the graph. So once the nitrogen analyzer starts analyzing the expired air, the initial phase 0 will have air from your conducting airway, which will have 100% oxygen. Okay. In phase 2, once the anatomical dead space and the air from the alveolar space, okay, alveolar volume get mixed, and the concentration of the nitrogen increases as we go through the phase 2. And phase 3 is from the alveolus. And this, can you explain this phase 4?
Phase 4, basically the small airways. Now at the end of the phase 3, the small airways gets to close. Now there's sudden rise in the phase 4 because of the amount of air which is more in the larger alveoli. They get coming out now. So this increase is because of that. So that point corresponds to the closing capacity.
Yeah. Where is the large alveolus present? Is it in the apex or in the base?
Larger alveoli basically on the apex.
Apex. So when the apex, the air from the apical alveolus, when they means when they expire, you get the phase 4. That is a closing capacity. Okay. So if you mention all these points, I think that should be more than enough for this Fowler's method. So for further explaining about Dr. Deepak's last point of discussion, the alveolus in the basal lung will be in this part of the curve, which is the most compliant part of the curve. And the alveolus in the apex will be in this part of the curve, which will be this, they will have a larger volume and less compliant. And once they start closing, the amount of air which, or once you start breathing, the amount of air going into this part of the alveolus is very less, but the maximum ventilation goes to the basal alveolus, because this is the most compliant part of the curve in which the basal alveolus are present. Okay, so this graph you have to remit to your memory, because anywhere in your Viva, this graph can come handsome to you, because this could be explained in your critical care Viva about your compliance in your ARDS, or it could be in physiology Viva. Okay, so this graph you should remit to your memory. This is one of the very important graphs. Okay.
So one thing, can I ask? So many times this graph starts from the zero, like the residual volume which you have shown. It starts from the zero only, and somewhere it's starting from the plus value. So is there any difference between that?
I didn't get it. Means zero means in the x-axis or in the y-axis?
On the on the y-axis, the tail of the graph is like you have shown till the positive side. Many books it's shown from the zero only. They don't let the tail fall till the positive side.
See, the residual volume is the volume which is present even after you cannot expire your residual volume. I think you should have a gap from the x-axis. So there should be some amount of air present even after you forcefully breathe out. Okay, so you cannot have it near the zero. There should be some amount of air. Can others please mute yourself? Okay, so you should leave, I think we should leave a space from zero, because you cannot entirely expire your lung volume. There should be residual volume. So that comes to this part of the curve. Okay.
Okay.
So next, going to the Bose equation, which you already mentioned. So this is the basic equation, that is a tidal volume, which is nothing but the addition of sum of alveolar ventilation volume and the dead space volume. Okay. So if you rearrange, so it will be VT minus VA, isn't it? This is what you were mentioning it before.
Yeah.
So the normal values are 20 to 35%. And we are interested on the fractional concentration of the alveolar carbon dioxide, fractional concentration of the end-tidal carbon dioxide, and the dead space carbon dioxide. So we have to remember, in the dead space, the fractional concentration of the carbon dioxide is zero, isn't it? Now, so again, going to the equation, and to know the amount of the carbon dioxide, we multiply the volume with the fractional concentration of each component of the carbon dioxide, isn't it? This is what you mentioned in your equation. Then we apply that the fractional concentration of the dead space carbon dioxide is zero. So this part gets deleted. So VT into VE is equal to VA into VA, FA. Once you substitute this in the equation, you can expand this equation and rearrange it to bring the VT on one side, and you get the ultimate final derivation. So once you get this equation, you already told us that alveolar carbon dioxide concentration is not equal to arterial carbon dioxide, and the expired carbon dioxide is equivalent to the end-tidal carbon dioxide. Okay, so you substitute that and you get the final equation which we mentioned here. Okay.
Yes.
So these are the maximum questions they will ask you. Mostly clinical applications they may ask you on this topic. So be prepared. So most important, the graphs are Fowler's method. okay, and the Bohr's equation, derive it and keep. So these, they may go in detail in your Bohr's equation, and you should be able to explain it to threadbare. Okay. Okay. Next question is a ventilation perfusion. So anybody wants to add anything to the previous topic? Okay. So next we'll go to the ventilation perfusion. So if suppose this is your main question, explain in detail the ventilation and perfusion ratio in an upright lung with suitable graphs. They may add one or two clinical scenarios to this question, or it could be just an open-ended question which they can leave it for you to just talk through.
Yes, sir. So, sir, I am just drawing the graph.
Yeah. Okay. Now.
So, sorry.
Yeah, go ahead.
So, ventilation perfusion, we can show that this graph.
Very good.
Is it?
Visible,
on the x-axis, we mark the from left to right, we mark from bottom to the top. And on the y-axis, we measure the flow in liters per minute. And on the z-axis, we measure the VQ ratio. So the ventilation decreases from the bottom. So ventilation decreases from bottom to the top. And likewise, perfusion also decreases from the bottom to the top. But perfusion decreases, the ventilation decreases more as compared to the I can say in other word round, from top to bottom, ventilation increases and perfusion also increases. But ventilation.
You are right. Actually, you are right. Suddenly you got confused. Yeah, actually, if you move from base to apex, you are going through your graph very well. And you told that the ventilation increases in the base as we go from apex to base. And even the perfusion increases from apex to base. But the steep of the slope of the curve for perfusion is more than the ventilation. This is the only point that you wanted to tell, right?
Yeah. So the apex constitutes a kind of dead space because here perfusion is more than the ventilation, and the base constitutes like kind of a shunt where the ventilation is more than the perfusion.
Very good. Okay. Good. 1 minute. Yeah. Okay. So now we'll go into this. So can you elaborate about west zones?
Yeah. So west zones were described for an upright lung, and it divides the lung in 3 zones: zone 1, zone 2, and zone 3. Zone 1 constitutes the uppermost part. I just draw the diagram. So zone 1 is the uppermost part in which the alveolar pressure is more than the arterial pressure, which is more than the venous pressure. So the alveoli are distended here, and the arteries got constricted. So these alveoli are larger alveoli, as we talked previously, and here there is lesser of the blood flow. Normally, this zone does not exist, but in cases where there is increase in the pulmonary arterial pressure, like in cases of hypotension, there is a in the positive pressure ventilation, this zone decreases.
Whenever there's a positive pressure, then this zone increases. Okay, no problem.
Yeah,
no
zone
problem.
increases. So this zone increases in case of when there is increase in pulmonary arterial pressure. So in pulmonary positive pressure ventilation, and also when there is hemorrhage, the pulmonary arterial pressure decreases. So this zone increases. Normally does not exist.
Okay.
Now comes the zone 2, the middle zone. In this zone, there is Starling or the hydrostatic pressure effect. So as we move down this zone, the due to hydrostatic pressure, there is pulmonary arterial pressure is more than the pulmonary alveolar pressure, which is more than the pulmonary venous pressure. So here it is governed by the arterial alveolar gradient. Here there is maximum ventilation perfusion matching, and in zone 3, the pulmonary arterial pressure is more than the pulmonary venous pressure, which is more than the pulmonary arterial pressure, pulmonary alveolar pressure. So here the blood flow is governed by the arteriovenous pressure difference.
Okay. So where will the shunt occur? Where is the dead space, which you already spoke about?
The zone 1 constitutes the dead space, and zone 3 constitutes the shunt.
Okay. So when you get such questions, so you start with describing the best zones, as you said, zone 1, zone 2, and zone 3. And once you can tell zone 1, zone 2, zone 3, they know that there are 3 zones, and then start explaining about each zone. As you explained that pulmonary, means the alveolar pressure was more than the arterial and the venous pressure. And you also mentioned about the physiologically, in a normal physiological situation, it doesn't occur, but it increases, the zone 1 increases during positive pressure ventilation and during a hypotension, isn't it? And in zone 2, it is the difference is between the arterial and the alveolar pressure. And this is known as Starling's resistor, or okay. And the difference is between the arterial and the alveolar pressure. And suppose this is the best zone for VQ, isn't it? It's almost equal to 1 VQ. And zone 3, where you have the difference between the arterial and the venous, the blood flow is always present throughout the systolic and the diastolic, and it is always more than the alveolar pressure, and there is a possibility of shunt. Okay, you can add 1 or 2 clinical situation to 1 or 2 clinical situation to the zone 3 and 1 or 2 for the zone 1. That completes your answer for this. Okay, so you can talk about left ventricular failure, pulmonary edema. Okay, for zone 3, where you have increased shunt fraction, or you can talk about ARDS or pneumonia. Okay, where you can have more shunt zone. Okay. Anything want to add? Anybody want to add anything to this?
One thing, like we place the tip of the pulmonary artery catheter in the zone 3 usually.
Zone 3, okay. Our aim is to place the artery in the zone 3.
Yeah.
Yeah, but we do not know. But how will you know?
We do not know, but
but if you come with this, then they will ask you, how will you know? How will you know that it is in zone 3? Is there any possibility that to know?
Yeah.
Do you know how to tell it is in zone 3 or zone 2? So it is like you have to increase the tidal volume or PEEP. Okay.
Okay.
Where you can see the changes in the pressure, and you can say whether it is in the zone 1 or in the zone 3. Okay. But once only you know very well, then you commit. Otherwise, do not commit. Okay.
Okay.
Explain the relation of ventilation and perfusion from apex to base, which you did, and what is VQ mismatch, and what are the causes of VQ mismatch. So we spoke about you can talk about pulmonary embolism, where there is increased dead space, isn't it? Because
yes, sir.
That increases the VQ mismatch. You can talk about ARDS, and left ventricular failure is more commonly asked. So when does zone 1 become clinically apparent? 2 situations, that is whenever you initiate positive pressure ventilation and whenever you have hypotension, it becomes clinically apparent. And what is the effect of lung on pulmonary perfusion? Do you have any effect of lung volume on pulmonary perfusion? Or you can tell pulmonary venous or pulmonary vascular resistance.
Yeah. So the pulmonary vascular resistance is dependent on the lung volume. The least pulmonary resistance is at the FRC level.
Very good.
Above FRC and below FRC, both the pulmonary resistance increases. So the above the FRC, it increases because of the stretching of the alveolar vessels. Because of those stretching.
See, you told first sentence was very good because you said the least pulmonary vascular resistance is at the FRC. Okay. Now you extend your answer to high lung volume and low lung volume.
Yes,
when
sir.
you have high lung volume, as you said, there is a stretch of the alveolus which is on the arterial system, which increases the resistance. Now you come to the low lung volume. Now what happens in the low lung volume?
In low lung volume, I read, sir, but I didn't, get much about this low lung volume. How is affecting the
in
PVR,
low lung
basically.
volume? What happens is the alveolar size reduces, which causes a tractional, which causes a radial traction on the vessel. That increases the pulmonary vascular resistance to a certain extent, but not as is seen in the high lung volume. Okay.
But if it going to put a traction on the vessels, so isn't it like it increases the rather than increasing, it decreases because the vessels got dilated? Is it?
No, it puts a tangential traction. So it is almost like you're occluding with a traction on the vessel. So there will be a slight increase in the resistance, not as seen as the high lung volume. Okay, that's the explanation given. So we knew this West zone, so they expect you to have this relation written already. Okay, write in your paper in those 10 minutes about this zone 1, zone 2, zone 3, and write few examples for causes of VQ mismatch so that you can talk over it. At least 1 or 2 words you can talk over. And you have made this graph. And do not forget to mention this VQ curve also.
Yeah.
Okay. And as you said, in y-axis, you mentioned flow in liters per minute. And in the x-axis, you drew from bottom to top on left to right. And you had a VQ ratio on your right side, isn't it? And you also showed a perfusion and the ventilation changes from bottom to top, with perfusion having a steeper slope than the ventilation. So this is what grossly you have to mention. And the VQ, if possible, try to draw this so that you show the VQ ratio of 1 somewhere in the middle. Okay. Now this is about the pulmonary vascular resistance and the lung volume. So if you see here, the FRC, the pulmonary vascular resistance is the least. And if you go to the, on the right side, if you increase the total lung volume, or the lung volume is increased on the right, then the total pulmonary vascular resistance increases, mainly because of the pressure on the alveolar vessels. And if you go to the residual volume, then there's a tractional compression of the vessels, which is mostly on the extra-alveolar side. So that also increases the resistance to a certain extent. Okay. So this graph is also important whenever you are talking about VQ. Next, the most important part of VQ is shunt equation. So there are 2 equations in respiratory physiology, which you should remit to your memory. One is Bohr equation and next is shunt equation. You should be able to derive the shunt equation and Bohr equation equally. Okay. So
yes, sir.
Try to write the shunt equation derivation before you face the examiner whenever you get VQ mismatch. So this is the shunt equation, which we all know, and define shunt in a short, in short, that is the lung, that is the areas of the lung that are perfused but not ventilated, which is seen in the zone 3 usually. Okay. And you can explain about extrapulmonary, intrapulmonary shunts, and you can give 1 or 2 clinical situations like physiological shunt and pathological shunt, like in ARDS and pneumonia, there is an increase in the pathological shunt. and you have extrapulmonary like congenital heart disease. Okay. Can we, the hypoxia due to shunt, can we correct it with 100% oxygen?
No, sir.
No. So we should, that we should be able to mention it in your answer. Okay. Try to draw this diagram and keep everything handy in your first 10 minutes. And mark all your parts correctly. And this is the long derivation, which I leave it to you because it is a simple equation. If you just go through it, it will be easy to understand. Yeah. And yeah, that comes to an end of your session. Good, Deepak. I think you gained a few points of how to improve yourself.
Yes,
there's a lot of scope to improve yourself.
Absolutely.
One thing in this session, mock viva, is you didn't have time. Which is almost like 10 minutes, which is very, very valuable. Now you understand why those 10 minutes are really valuable.
Yeah.
So this gives a lot of time for you to organize your thoughts and draw your diagram and keep all your graphs, relevant graphs ready. Okay, do not leave it to chance and try to make sure that you write all your units correctly. Okay.
Thank you, sir. Thank you.
Thank you.
Yeah.
So anybody wants to add to this previous topic? Okay. Next, we'll go to COPD. This is mostly, it will be discussed in table 3 or table 4. Dr. Sangeeta.
Hi, sir.
Yeah. Hi, good evening.
Good evening, sir.
So where are you from and when is your exam?
I am from Chennai and my exam is on November, sir. November 10, 11, 12th.
Okay, that's an online, is it?
Yeah, online.
Okay. So, so if you face a question like this in your table 3, take a minute to read and take 1 or 2 minutes to organize.
Yes, sir.
So you have a case of 70-year-old male who is admitted for total hip replacement for his arthritis.
Yes,
and
sir.
he is a known diabetic and COPD. And
Yes,
he's
sir.
on metformin 1 gram a day. And he's receiving regular nebulization of salbutamol thrice a day and ipratropium twice a day. He was admitted with pneumonia 8 months ago in hospital. This is the only past medical history, and he quit smoking 3 years ago. How will you plan the perioperative management of this patient? This could be your main question for your table 3.
Yes,
and
sir.
you will spend a good time on this question, though you will have 3 or 4 questions in your table 3. This will be your first 5 to 8 minutes will be spent on this question. Okay.
Yes, sir.
So once you get such a case, so try to organize the question stem mentions only how will you plan your perioperative management. So then you can write or you can organize your thoughts for your perioperative management, like pre-op assessment, intra-op management, and post-op management. But you may face further questions from your examiner as you start talking. Okay.
Yes, sir.
Okay. So suppose you go to the table and I ask you, what is COPD? Can you define COPD?
Yes, sir. COPD is a chronic obstructive pulmonary disease, and it is a common, preventable, and treatable disease characterized by persistent airflow limitation and some inflammatory changes to both the airway and the lungs to the noxious particles or gases. And it comprises of 2 different entities like chronic bronchitis and emphysema.
Okay. So it's a chronic airway inflammatory disease which presents with
persistent airflow limitation.
Yeah, cough and dyspnea. Okay, productive cough for the past at least 2 years. That's at least 3 months of productive
3 months
cough.
For the consecutive 2 consecutive
2 years. At least. Okay, so that definition you should mention. Okay.
Yes, sir.
And as you said, there are 2 types: emphysema and bronchitis. You can go ahead. Yeah, keep talking. Yeah.
Yes, sir. As you mentioned, like chronic bronchitis is the chronic production of cough for more than 2 months for the 2 consecutive years, and emphysema is defined as the presence of permanent dilatation of the airway distal to the terminal bronchioles.
Okay.
Yes, sir. And it can be due to like first major cause is due to smoking, and second is due to like environmental pollution, occupational hazards like coal, gold mining, and due to genetic causes like alpha-1 antitrypsin deficiency. All these can cause, and sometimes due to malnutrition also can causes COPD, sir. And coming to the symptoms, the major symptoms are dyspnea, chronic cough, and sputum production. So coming to this case, the patient has come for total hip replacement, and he has diabetic, and he's a known case of COPD, and he's on medications, and he has the history of pneumonia like 8 months ago, and he's a known case of smoker. And
Okay.
from the
Any
history
other,
of
no, you mentioned about cough and dyspnea and sputum production. Do you know any other pulmonary, extra pulmonary manifestation of COPD?
Yes, sir. Like extra pulmonary is the patient will have there will be polycythemia because the patient will present with the chronic hypoxia, and there will be cyanosis, and there will be clubbing, and there will be presence of signs and symptoms of right heart failure will be present, like facial edema, pedal edema, JVP will be elevated, and there will be tender hepatomegaly, and other signs of right heart failure will be present. So,
Okay.
and we should ask the history of cough, and we should ask the history of sputum production. That is the characteristics of sputum production, the amount of sputum, and color of sputum, and diurnal variation, and order of sputum, and positional changes in which the patient is getting the sputum more. We should access that, and we should calculate the pack years, and the smoking index should be calculated because to calculate the post-operative pulmonary complications, we should calculate all this from the history taking. So,
okay. So, how will you diagnose COPD?
First, I will do like a clinical examination. I will check for pallor because anemic hypoxia is very dangerous. So, in case of anemia, we should treat the patient beforehand. But most of the COPD patient will present with polycythemia, and I'll check for clubbing, cyanosis, and inspection. I'll see for the barrel-shaped chest, flattening of the intercostal spaces, and whether he is using his accessory muscles for respiration, and I will note the expiratory time, whether it is prolonged or not on inspiration, and I will see his tracheal position, that is whether it is in midline or not, and on palpation I'll check for his vocal parameters, and in COPD patient the vocal parameters will be decreased, and in percussion it will be more of hyperresonant, and in auscultation, and I'll check for whether he is having prolonged expiration, and whether he has any palpable P2 because of pulmonary hypertension.
Okay. So whenever you tell about how you diagnose you for any other disease, or when they ask you how to diagnose, always start with history, and then you go to the examination, and then go to the investigation. And when you go to the history and examination, we be very particular about what we are dealing with. Okay. And first you tell all the positive things so that you can get maximum marks in that. Okay. And you said from the history, sputum, dyspnea, productive cough, sputum production, and dyspnea. And you try to organize what is the dyspnea part. If you can classify how, according to the Medical Research Council, grading,
Yes,
the dyspnea severity grade. Then you spoke about the examination. The particular, you don't mention about anemia because you told that patient will have polycythemia. Don't contradict your statement.
yes,
Okay, you can tell about clubbing, all those things. It's okay, cyanosis and clubbing. You can tell about the evidence of smoking, like what is it, nicotine stains or okay.
Yes,
So those
yes.
could be pertinent. And then you come to the investigation.
Yes, sir. Like I will do the complete blood count to check the hemoglobin level and hematocrit level, and I will check for the leukocyte count to check the level of neutrophils or lymphocyte and eosinophil, and I will.
See, whenever you are talking about any investigation, you have to tell, you have to justify yourself why you are asking for this investigation. Let it be a hemoglobin. Okay,
Yes,
you
sir.
justify that you are looking for polycythemia.
Yes,
Once
sir.
you come for the total count, what are you looking for? You are telling
Total
about
count, whether it
neutrophil
is an acute infection or chronic
infection. Yeah, you have to mention about the word infection. Okay, so you want to rule out any infection. Okay, go ahead.
And then since the patient is on beta agonist salbutamol, I will check. I will order for like electrolytes, and for ECG.
Which electrolytes particularly you want to mention?
Potassium. And I will check for in ECG. I will check for like P pulmonale, that is the P wave more than 3 millimeter, or any right ventricular hypertrophy, that is RS ratio is more than 1 or not. And I'll check for whether there is any low voltage complex and poor R wave progression. And since if the patient has none of the symptoms like fatigue, dyspnea, or any paroxysmal nocturnal dyspnea, then echo is not needed. And if the patient has such signs and symptoms, then I will suggest of echo. And
do not mention anything which is a controversy. Okay, so the examiner may think otherwise. Okay, so he may ask, why not echo? I will go for an echo. Okay, so you justify that I will ask for an echo if the patient is having. Okay, you justify your answer before committing to the examiner. Okay.
Yes, sir.
Yeah, go ahead.
And I will ask for a chest X-ray, sir, to check whether the patient has hyperinflated lungs, and whether there is parallel intercostal spaces, and whether the dome of diaphragm is flattened, and whether he has any tubular heart. And I will check the signs. I will check.
Good. You are telling all the features. You say, whenever I order an X-ray, okay, I look for a barrel-shaped check. There could be features of barrel-shaped chest. Then what is it? Hyperinflated lung. Diaphragm will be pushed down, maybe pushed down. Tubular heart. So these are some signs and evidences of having a COPD lung. That's enough. You concisely you talk. Okay.
Yes, yes, sir.
And then what is the next investigation which you'll go for? I will
go for spirometry, sir. And spirometry will measures all the vital capacities and volumes except FRC, residual volume, and total lung volume.
We are looking only for COPD. You have to talk about FEV1 by FVC. Do not commit about residual volume, all those things. Okay, he will ask for it. Okay, so FEV1 should be less than?
FEV1, if it is more, I will go with the gold criteria, sir.
Very
in
good.
that FEV1 and FVC ratio will be less than 0.7, and that comes under the obstructive category. If it is more than 0.7, it comes under the restrictive category. And in this criteria, FEV1 by FVC ratio, it will be less than 0.7. And then after giving the bronchodilator, we should calculate the FEV1 part. And if it is more than 80%, it comes under mild. If it is more than 50 and less than 80%, moderate. And if it is more than 30 with less than 50%, it comes under severe. And if it is less than, if even less than 30%, it comes under very severe.
Very severe. So you have to mention this criteria.
Yes,
Remember, anyway, either nice or gold, whichever you talk correctly. Okay. Next.
Yes, sir.
What will you see in ABG in this patient?
Yes, sir. In ABG, I will check for carbon dioxide level and oxygenation level, sir. Whether the patient needs post-operative oxygen supplementation or if the patient need any post-operative ventilation, and I will assess the gas exchange and oxygenation level from ABG, sir.
What is the particular value of oxygen you look for? Is there any particular value? 60
mmHg and carbon dioxide of less than 45 mmHg, sir. If it is more than that, then increase the chances of post-operative ventilation. Yeah, so you have to mention that in the ABG, I will look for respiratory acidosis, okay? Yes, sir. And the oxygen, I should be happy with the PO2 is more than 60 millimeters of mercury, and PCO2 of more than 50 or 55, some books say 55, some books say, so any value, okay, 50, then I will expect or anticipate increased post-operative pulmonary complication. Yes, sir. And if the patient is on home oxygen therapy, then I will continue. I will check for bedside pulmonary function test, sir. Okay. In that, first I will do Sabrat's breath holding time, and that is after the patient after deep in these examination, I should say they don't go much into clinical examination. They come more to the management. Okay, yes, no sir. Need to see. By and large, you should be able to describe the investigation and bedside clinical test 1 or 2. If the examiner is interested, he may ask. Otherwise, yes, they will just go to the management part. Okay. So you also mentioned about the classification of the disease severity based on the GOLD guidelines. And yes, now sir. You come to the preoperative optimization. Yes, sir. How will you optimize them preoperative? Preoperatively, like since the patient is diabetic, I will check for the. We are worried about only COPD here. So talk about COPD, then you go to the diabetes and hypertension. Yes, sir. First, I'll check whether the patient has any signs and symptoms of right heart failure, carpulmonale. I'll try to optimize the patient. You all checked. See, now you have to optimize. So I will 1, I'll do 2, I'll do 3. Like that, you have to bulleted points. You have to tell. I will ask him to stop smoking. Stop smoking. Okay, he's yes, already quit smoking. Okay, yeah. Then what will you do to improve his lung function before surgery? Yes, sir. I will follow the 5 prongs approach. That is the first one is the do not mention if you do not know the 5 all into. If you know 5, well and good. Mention the numbers. Otherwise, just talk to us. Okay. If you say there are 3 causes and if you are stuck with second cause, then they will ask you, don't know the third cause. Do not commit the numbers if you are not sure. Okay. Yeah. Go ahead. Yes, sir. Like I will suggest him to cessation of smoking, and I'll optimize the patient with bronchodilator, and I will loosen his secretion with adequate hydration, mucolytics, and I will advise the patient for any for physiotherapy like incentive spirometry and deep breathing exercises, and right. And if there is any active infection, I will try to give antibiotics to the patients. Patient. Okay. Then you can talk about optimizing the blood sugar, and I'll yes, optimize his blood pressure. And if it is high, I will take adequate measures to correct it. Okay. Yes, sir. Can you tell about a word about cardiopulmonary exercise testing? Can you give a brief detail about this? Is a cardiopulmonary. What is cardiopulmonary exercise testing? First, define cardiopulmonary exercise. Cardiopulmonary exercise is like stair climbing. We have to check the VO2 of the patient. That is maximal oxygen consumption during the exercises. That is called VO2, and I will do like stair climbing test and 6-minute walk test. sir. And if the patient is able to climb more than 5 flight of stairs, that is, one flight of stairs is 20 steps, and each step should be about 15 centimeter height. And if the patient is able to climb more than 5 flight of stairs, then his VO2 max is more than 20 ml per kg per minute. And if it is able to climb more than...
See, what you're telling is a very subjective test. Do you know any objective cardiopulmonary exercise testing?
Cycle ergometer.
You have to talk about it. Yeah, talk about it. Yeah. So this is, you define what is cardiopulmonary exercise testing is an objective method of assessing cardiopulmonary capacity of a patient. Okay.
Yes,
then you tell the patient is placed on a cycle ergometer and is connected to ECG, his vitals like heart rate, his blood pressure, and his breath is analyzed, saturation, and his breath is analyzed by each breath. And the resistance of the cycle is slowly increased as the patient starts cycling. Okay.
Yes, sir.
And you look for what?
Like the VO2 by VC, oxygen consumption and carbon dioxide excreted
elimination.
Elimination.
Yeah. So you are looking for these two.
Yes,
with these two parameters, what do you derive?
Like I will assess the cardiopulmonary reserve of the patient.
You have to mention about two things here. One is anaerobic threshold, and the other one is VO2 max. Okay. What is anaerobic threshold?
Can
anybody who wants to join? Okay.
While doing the exercise, it is the threshold beyond which the lactic acid clearance and the this thing falls short of providing the oxygen, where the anaerobic metabolism takes over, and that is the threshold which leads to the...
Hello. Yeah. Yes, sir. Hitendra, sir. Yeah. See, this is the VO2 at which the...
Hello.
Yeah, Dr. NG.
Yeah. I just want to since your anaerobic threshold is also known as the lactate threshold. It represents a shift to the anaerobic metabolism during exercise. So the gold standard is for measuring the lactic acid or the trend of the serum bicarbonate during exercise, and usually it is normally occurs at more than 40% of the predicted VO2.
So there is a point at which the anaerobic threshold is will supplement your aerobic metabolism.
Yes.
Isn't it?
Okay.
Yes.
Okay. So do you have any value to this? Less than this is 11 ml per kg per minute.
11 ml per kg per minute.
11 ml.
Yes. So you look for that value. More than 11 ml is associated with lesser morbidity, and less than 11 will be increased morbidity. Similarly, VO2 max is the maximum oxygen consumption of a patient. Okay, VO2 max. Actually, theoretically speaking, we don't measure VO2 max, we measure VO2 peak. Because for the same patient, the peak oxygen consumption can vary with the same exercise threshold. And we mention it as VO2 peak, and it should be at least more than 15 ml per kg per minute. Less than 10, it is associated with at least 18 to 20% of significant cardiorespiratory morbidity. Okay. So whenever you are going for this exam, there are some pertinent topics which they concentrate. Okay. So cardiopulmonary exercise testing is one such topic which you should concentrate in detail. Okay.
Yes, sir.
Yeah. So go about, read about it. There is a graph for it. So you may be asked in physiology or the basic sciences Viva in detail. So know about this exercise, okay? Now you can detail your perioperative. So you finish your preoperative optimization. Now you can come to the, this surgery is particularly for total hip replacement. Yeah. So what is your preference of anesthesia?
Since the patient is for total hip replacement, and I will go with the regional anesthesia, that is epidural with spinal anesthesia. Sir.
Okay.
And
you can tell about advantages. Whenever you're talking about a perioperative management of such disease, you can choose either GA or regional or whatever. Okay, but you have to substantiate your answer. I will choose regional anesthesia for following advantages.
Yes, sir.
Yeah.
Since the surgery is for the lower limbs, since the patient airway is compromised, I will preferably go with the regional anesthesia. Since the regional anesthesia will provide better relaxation, better post-operative pain relief, and it also does not deals with the manipulation of airway. And so I will preferably go with the regional anesthesia for this patient. And the disadvantages is if the patient is on active infection, I will try to optimize the patient, and I will take all the
elective surgery. So this is an elective surgery. No, this is an elective surgery. So you can optimize the patient and reschedule him after.
Yes,
okay.
Yes,
so okay, so that one, and it also aids you in reducing the chances for DVT and thromboembolism, which is a very big concern in a COPD patient. Though there are no correct answers, but there is no evidence, but it is way better than general anesthesia. Okay, suppose if the same patient comes for a laparotomy, you are held only with general anesthesia.
General anesthesia.
Okay. So if you are forced to give a general anesthesia, what will be your ventilatory strategy?
I will go.
What will be your mode of ventilation which you will prefer?
Sir, I will go with the pressure control ventilation with the low peak inspiratory pressure, and I will keep the expiratory ratio a little much prolonged, and the PEEP will be of minimal of 3 to 5 centimeter of water, sir. Since the patient has more chances of getting auto PEEP, developing auto PEEP
or intensive PEEP. Okay.
Where are you going?
Hello. Yeah.
Hello. Yes.
Yeah. Can you hear? Yeah. So you can tell about. I will go for pressure control ventilation because it will distribute the tidal volume much better than the volume control. And the pressure control can have some advantages of limiting the inspiratory pressure. And as you said, you decrease the respiratory rate and increase the expiratory phase. And you can increase, play with your IE ratio. That is, you increase the IE ratio and you avoid keeping PEEP. So these are the some intraoperative ventilatory strategy. Suppose, okay, you extubate this patient and then explain about your post-operative plan for pain. You said you had epidural, isn't it?
Yes.
Other than epidural, do you want to add any other medication or you want to avoid any other medication?
I will avoid any prolonged sedatives, high dose benzodiazepines. I will avoid high dose benzodiazepines, prolonged usage of opioids.
For pain, yeah. Okay.
I will avoid opioids, long duration opioids, and and I will avoid. I will use only short acting opioids, sir, and NSAIDs. I will avoid NSAIDs.
Okay. So you can tell that post-operative plan for pain will be a multimodal analgesia. You start like this, okay? Once you start like this, your half answer is done. Multimodal analgesia, I will include paracetamol, okay? And, and then low dose.
Opioids.
Opioids you want to avoid. You said you wanted to avoid opioids, right?
Yes, but low dose of short-acting opioids I can give, sir.
Like what?
Fentanyl, low dose of fentanyl.
Okay. So see, that's what. You don't commit one sentence and don't contradict yourself. You said, I want to avoid opioid.
Yes,
so
sir.
Stay by that. And then you said multimodal analgesia, you can include paracetamol. You said you wanted to avoid NSAID for fear of bronchoconstriction, okay, any bronchospasm. And you can activate the epidural analgesia.
Yes, sir.
Okay. And intraoperatively, you will also use any other drug to prolong your effectiveness of your local anesthetics like dexamethasone.
Dexmedetomidine.
Okay.
Yes, sir.
Dexmedetomidine. See, these are all some evolved. We are doing in practice, but maybe it is not so widely accepted till now. Okay.
Yes.
So do not fall into a trap of if suppose that examiner didn't know about dexmedetomidine or something like that. If he asks particularly probes into it, yes, commit to it. But
Yes,
be very bland in your thing that these are the things which I will do, I will not do. Okay, don't go into very controversial topic and create trouble for yourself. Okay.
Yes, sir. Yes, sir.
Okay. Any other medication you will add to COPD patient in particular, other than pain? Means you will continue all his regular medications like inhalers and all. And always mention about low molecular weight heparin.
For
Okay?
DVT. Yes, sir.
For DVT profile. They always look for it in COPD patients. Okay.
Yes, sir.
And you will also mention about controlling his comorbids, continuing all his preoperative medication. Okay, like metformin. If the sugars are not controlled, I will go and switch into insulin. Okay. Then for hypertension, depending on the blood pressure, I will modulate his blood pressure tablets. Okay.
Yes, sir.
Then any other thing about oxygenation you want to mention about this post-operative oxygen requirement?
For post-operative, I will advise the patient to do respiratory exercises like incentive spirometry, and I will advise to do the deep breathing exercises. And
supplemental oxygen should be kept as minimal as possible. Okay. Because they are dependent on their hypoxic drive. Isn't it?
Yes. Yes, sir.
So you should mention these important points for. Okay, so you have to mention about these important points in your post-operative plan. Okay.
Yes, sir. Yes, sir.
So you told about this chart, that is FEV1 by FVC of less than 70%. And depending on the FEV1 of predicted, you can classify either according to the GOLD classification or NICE guideline. Whichever you mention, you can do that, no problem. If they are particular about flow volume loop, they will ask you to draw the flow volume loop. So in respiratory physiology, all the graphs are important, like your pulmonary function tests are really important, because you can get this flow volume loop as a separate question. It's a main question. Okay, you should know all the intrathoracic, extrathoracic, restrictive, obstructive, all the flow volume. You should be able to draw and try to explain the flow volume loop. Can you see this diagram on the screen?
Yes, sir. Yes, sir.
Can you explain this flow volume loop?
It is the flow volume loop of lower airway obstruction, and this graph shows the scooped out airway of in the expiratory phase, and it is most probably the case of diagnosed emphysema.
Okay. See, whenever you're talking, you say first you describe the flow volume loop. The loop which is on the below the x-axis is the what phase?
Inspiration phase.
Inspiratory phase. And the loop above the x-axis is the expiratory phase. Okay. And in this loop, there is, as you said, there is an extreme concavity in the expiratory, scooped out appearance in the expiratory loop, which is pathognomic of obstructive lung disease. Yeah, obstructive lung disease. And there is a increase in the residual volume, mainly because of the air trapping. Okay, and the total lung capacity of this patient will be increased. And so these are some important points which you should be able to explain in the flow volume loop. Okay. So this we spoke about cardiopulmonary exercising test and anaerobic. These two values you should commit to your mind: 11 ml per kg per minute, and VO2 max or VO2 peak of less than 15 ml per kg per minute will be associated with more than 18% of significant cardiovascular morbidity or cardiopulmonary morbidity. Okay. If they ask you to draw the diagram of anaerobic threshold, you should be able to mark the X and Y axis with VCO2 in Y and VO2 in the X axis and show the anaerobic threshold. Okay.
Yes, sir.
So other topics which will be asked or discussed in this topic is preoperative smoking cessation. What will be the time duration to ask the patient to stop smoking if the patient was smoking? What do you think? What is an ideal situation?
Sir, the half-life of carbon monoxide is 4 to 6 hours.
Do not commit to this. Be specific. I asked, what is the ideal preoperative smoking cessation? It's a one-word answer.
8 weeks. 8 to 12
8 weeks. Do not go into half-life of carbon monoxide. Then he will go into carbon monoxide poisoning. Why are you trapping yourself? Okay. Be very specific in answers so that you will get more questions to answer. Okay.
Yes, sir.
Then medications, you mentioned about preoperative optimization of your this one inhalers, and you can mention about oral steroids. Okay. Antibiotics you mentioned about low molecular weight heparin. Then intraoperative choice, you spoke about regional anesthesia. So you should know the difference between when you will choose general anesthesia, when you will choose regional, and substantiate your answer. Okay. Yes. And ventilator strategies and intraoperative complications. Usually they will ask for suddenly the patient on GA undergoing a laparotomy, bronchospasm. How will you diagnose? How will you approach? How will you treat? Okay. You should have very specific answers to this. So you should look for, if the patient is under GA, what will you look for to diagnose bronchospasm? Suppose the patient is having bronchospasm, how will you proceed?
The peak, I will check the ventilator, the peak airway pressure will be increased, and I will auscultate the patient, and there will be reduced or no air entry will be present, and the saturation level also the patient will be desaturating. And so for the management, I will increase the FiO2 to 1.0. And if the patient is in nitrous oxide, then I will cut off the nitrous oxide, and I will deepen the plane with either inhalational or intravenous anesthesia, and I will give like inhalational beta 2 agonist like salbutamol, and then I will give either intravenous steroids or intravenous aminophylline.
What steroids will you look for? You will give, and how much will you give?
I'll give like
hydrocortisone.
Hydrocortisone 100 mg.
100 milligram IV. Mention the drug. Yeah. Okay.
And
okay. So whenever you face such situation like hypoxia, pneumothorax, hypotension, or bronchospasm, first tell how to identify. Okay. So you told whenever you look for increased inspiratory pressure, immediately auscultate the patient. Okay. First you have to. There should be a methodology in your assessment, from patient to machine or machine to patient, whichever way you want. So I will auscultate the patient and then rule out any spasm, or if there's a spasm, then I will look for any kinking of the tube. Okay.
Yes,
Then
sir.
you can go to the machine end and you can work up your way. And then you, as you said, you will start the, you can give 1 or 2 puffs of salbutamol inhaler, and you can give intravenous steroids. You can give aminophylline or theophylline, whichever you have. Okay, and then you can always mention about magnesium. 1 or 2 grams of magnesium can be given to relieve bronchospasm. And you can also give a suction to the tube because there could be possibility of secretion blocking the tube. So try to, you relive your experience in your theater, whichever way you're going to do in your patient, you just enumerate and be very casual and do not worry about, even if you commit something absurd, no problem, but be very specific. I will give injection hydrocortisone, 100 milligram IV. I will give 2 puffs of salbutamol. Okay, and I will be very specific. Okay. Then post-operative pulmonary complication. So I will continue the preoperative spirometry, incentive spirometry, minimize the oxygen as much as possible, and do not exceed the patient requirement. If the patient is on 2 liters per minute oxygen preoperative, I'll continue the same amount in the post-op. Okay. And talk about post-operative analgesia and thromboprophylaxis. Okay. So other potential topics for discussion in such cases is effects of smoking. Once you commit carbon monoxide half-life, they will go into the effects of smoking and other things. Okay. And intraoperative pneumothorax bronchospasm. Sometimes they may ask about workup for lung reduction surgery. How will you work? Suppose this patient is coming for a lobectomy, for a bulla. Okay. Suppose he is coming for a right upper lobe. They may deviate from the main case. What you see in the main stem will be for total hip replacement. Sometimes that patient, person, the examiner may have some thoracic experience. He may take you to lung reduction surgery. We never know. So always be ready for workup for lung reduction surgery. How will you work up? There is?
Sir, I will do the some.
Okay, pulmonary function test is the most important test. No, first is a pulmonary function test. If it is your FEV1 is more than 1.5 liters, then he is suitable for lobectomy. If he is more than 2 liters, then he is suitable for pneumonectomy. Okay, there's a chart. You just go through the chart. And if he is less than these 2 values, then the next is you will go for DLCO. Okay, or predicted post-op, the quantitative studies, quantitative lung studies like DLCO and predicted post-operative function FEV1. Okay, if it is more than 40%, then you can go ahead for the surgeries. And if it is less than 40%, then you have to go for cardiopulmonary exercise testing. Then if your VO2 max is more than 15 ml, then you can proceed for the surgery. If it is less than 15 ml, you should go for other alternative methods. So there's a chart, simple chart, just go through it and it may be asked. Okay? And one lung ventilation is there. They don't want very nitty-gritty of one lung ventilation. They want by and large the principles of one lung ventilation. How will you do? Okay, what are the indications? What are the contraindications? What are the methods to do isolate a lung? Okay, these are some broad headings they will expect to talk about. And management of one lung ventilation, the physiology of one lung ventilation. So if they touch the physiology of one lung ventilation, they will definitely ask about hypoxic pulmonary vasoconstriction. Okay, and how to reduce hypoxic pulmonary vasoconstriction, and how to manage intraoperative hypoxia after you isolate the lung. So this will be the favorite questions in such cases. Okay, so that is hypoxia management intraoperative. Good, Dr. Sangeeta, I think you had some experience about, okay.
Yes,
and see, when such cases come, don't become nervous, okay. You may have your favorable case or your known case, or even if you don't know anything, just take a minute, sit back and think for a minute and then answer. They don't push you to answer hurriedly. They don't, in fact, in my third table, I spoke so fast that the examiner told that you have 2 more minutes. Why are you rushing? So she got exhausted with all the questions. He said, 2 more minutes, what to talk? We do not know. So try to make yourself in a paced manner. So you answer many questions. And whenever they ask you any questions particularly, try to completely answer that question. And then you can take the examiner to the next level by giving a small thread in the end. Suppose, as you said in the smoking, the effect of smoking, in the end, if you know about carbon monoxide very well, you can leave a thread of carbon monoxide. Then he will catch that and he will go to the, so you can guide your examiner also in that way. But they don't deviate much because they have a written format in their hand. But to a certain extent, you can play your Viva. Okay.
Yes.
Any other questions, any other comments or suggestions from others? Oh, somebody, Parin has mentioned 7 to 8 puffs of salbutamol. See, it is not 7 to 8 puffs. It is like we give a titrated dose. You just give 2 puffs each time, and you see the response. And if you give 7 to 8 puffs, then the patient can have significant tachycardia. Okay.
I think the question was pertaining to general anesthesia, so I think it's better to say nebulization. I'll nebulize
nebulization
patient with the salbutamol or ipratropium bromide combination.
Yeah, but it is intraoperative, so intraoperative GA.
Yeah, the intraoperative GA. The question was led by the intraoperative GA patient developing bronchospasm and how to manage it. So IV and inhalational.
Yeah. So any other comments or Shiv, sir?
This is my first time today I joined, and I'm quite happy. I'm thankful to Shiv sir for allowing me to be part of this group, and quite a learning bit for me as well. I'll be appearing in September. I could not get an online date, but then I could secured a place in Poland in September, and so looking forward to give this exam in September with acquiring knowledge from all you expert people.
Nothing, sir. We are all learning from each other. So this is a great platform for me also to improve myself. Any other comments, questions? If it's done, I think we can wind it up here. Thank you everybody. Thanks, especially Dr. Deepak and Dr. Sangeeta for taking this extra effort to prepare.
Thank you, sir.
Thank you, sir. Thank
All
you.
the best for your
It was very nice
session. Yeah, all the best for your exams.
Thank you, sir. Thank you.
Thank you, sir.
Shiv, sir.
Thank you, sir.
Well done, Deepak and Sangeeta.
Thank you, sir.
Thank you, sir.
Sir, any comments you want to, or any additional information?
No, I think it's all about practice, Vivas, isn't it?
Okay. Yeah.
The more you practice, the better you get at it. So you need to actually get practice. Just catch anyone and say, ask me anything. It doesn't have to be specific, but you just practice Viva. And you should have that good flow.
Yeah. Okay, sir.
Okay.
Thank you.
See you. Bye.
Thank you. Good evening. Bye-bye. Bye.
Bye.
Thank you.